going to talk about uterine fibroid embolization, but usually radiologists do not get many referral from gynecologists. I think it's more about the political issue, but still we have to understand the principle of the technique. Current treatment options for uterine fibroid include surgery and medication, and UFE, and also HIFU. And now it comes to ablation. The ablation can be approached from percutaneous or laparoscopic or transvaginal, but most of the techniques are controlled by the gynecologist. We can perform only UAE right now, or MR-guided HIFU, but I think gynecologists, they are more in favor of ultrasound-guided HIFU because they have the tool in hand. But I think the successful treatment of fibroid depends on the patient selection. There is no single tool that can fix all the problem. So there are different character and different location of fibroids, and that may suit for different kinds of treatment. For UFE, we're looking for symptomatic patients. The symptom of uterine fibroid includes abnormal menstrual bleeding, monorrhagia or polymenorrhea. The patients are usually anemic, having anemia, chronic anemia. And they can also have pressure symptoms like frequency or abdominal fullness or constipation, depends on the location of the fibroid. If the fibroid is in anterior location, it causes the urine frequency and abdominal fullness. For posterior location, it may cause constipation. And for submucosal or bigger or multiple fibroids, the abnormal menstrual bleeding is very common. And it is also interesting that menorrhagia has no absolute association with fibroid location. So with the knowledge in mind, I think pre-UFE imaging study is important. And of course, the pre-UFE MR is the best imaging tool for evaluation. It has been surveyed in the old literature that the pelvic MR may alter treatment planning prior to UFE in up to 15 to 20% of the cases. So what are we looking for in the pre-UFE MR? First, we have to understand the location and number of myomas. We need to understand is the character of myoma can explain the symptom of the patient. And also, if we are treating a different location and different size of the myoma, we may have to be careful about some complications, such as if you are treating submucosal, pedunculated, or too large myoma, you may expect the expulsion of the myoma after the procedure. And the character of myoma is also important, including the vascularization and the location of the myoma, such as the cervical leiomyoma may have poor response to UFE. And we also have to look for coexisting uterine pathology. If the patient has also adenomyosis, then you can expect early recurrence of symptom or poor response of the treatment. Or you may have to select smaller particle size for adenomyosis. And also we have to look for other pathologies, including polyps, hyperplasia, carcinoma, or other pelvic pathologies such as infection or endometriosis. And of course, the most important is that we have to understand there is a possibility of leiomyosarcoma, which we don't want to treat and delay the treatment for the patient. Here are some basic MR image of myoma. On the left side is the characteristic classic uterine fibroid, which shows T2 low signal intensity. And while on the right side, it is also benign myoma, but you can see it's high signal intensity on the T2 weighted image and strong homogeneous enhancement after contrast injection. This is the cellular hypercellular uterine myoma. It is also called white fibroid in the old literature, and it may indicate a good responder to UFE. And the myoma can be totally pedunculated in endometrial cavity like this, or it can be intramural location like this. And it can show different kinds of degeneration. For example, this is a very common type of degeneration, which you can see low signal intensity on T2 and high signal intensity on T1, and no enhancement, which means it has red degeneration, which means infarction. So if it's a hemorrhagic degeneration, myoma, it can respond poor to the embolization. On the contrary, if that is a white fibroid, it may respond good to embolization. And as we said, cervical fibroid is a poor responder to UFE, so it is considered as the contraindication for UFE because its blood supply is different from the classic myoma. The cervical fibroids, because it may be supplied from the cervical vaginal branch, so its arterial supply is usually fine and without a main feeding vessel. So, for example, like this one, you can see this is the cervix, and the myoma is protruding to the backside, from the backside of the cervix, and also the lower uterine segment, and it is very large. And this is the ovary here, and this is the combing CT image. You can see the arterial supplies from the bilateral cervix, and it is very fine, and there is no main feeder for this artery. So we performed UFE for these patients, but at first the patient felt that the pressure was decreased, but soon, not long after, the symptom come back, and there is no obvious shrinkage of the tumor. So this is not a good indication for the procedure. So again, the main indication for UFE is that the patient has to be symptomatic. If she is not symptomatic, then she feels nothing after treatment. So she may be satisfied for the procedure. And again, the contraindication, the absolute contraindication include pregnancy status, and the coexisting pelvic malignancy and active inflammatory disease, or allergic to contrast medium. And the relative contraindications include pedunculated myoma. If the myoma is pedunculated subserosal type, then it was said that if the pedicle was no less than 1.5 centimeter, then it is not considered a contraindication. But if the pedicle was very thin, then you have to be careful about the possibility of falling of the myoma into the pelvic cavity after the procedure. And then cervical leiomyoma and profound adenomyosis, and also hemorrhagic or degeneration leiomyoma. They are all relative contraindications. And another one is extra large myoma. It is usually also poor responder to UFE procedure. Another principle is about the particle size. We are looking for the embolization for the perifibroid arterial plexus, which is around 500 to 700 micrometer calibration. So usually we use the particle size more than 500 micrometer. It is safe to normal myometron and also for ovary, but it can occlude the myoma vessel. So for left to right anastomosis, there are usually anastomosis similar to prostate. The anastomosis is commonly existed. The left to right anastomosis is about 10%. And also, there is a common anastomosis is uterine to ovarian anastomosis. It is about 10 to 30%. But if you choose particle size larger than 500 micrometer, it should be considered safe for the procedure. Okay, so this is the typical procedure we do for uterine artery embolization. By selecting the bilateral uterine arteries, you can see the entire perfusion of the uterus and also including the myoma. And then you just embolize in the bilateral uterine arteries, and until when there is only main trunk depth, then the procedure should be considered done. Here are some cases. This is intramural myoma. The patient has polymenorrhea and with very low hemoglobin, which is 8.5. This is not uncommon for female patients with myoma. Their hemoglobin are usually very low. And so this is the post-embolization appearance. You can see the myoma is completely infarcted. And after 3 months, her hemoglobin elevated up to 12. So this is a very good responder to the treatment. This is another example, a submucosal myoma, also very low hemoglobin. And after the procedure, the myoma just completely infarcted and shrinkage a lot. After 2 years, her hemoglobin was 15.5, which is very good. And this is a case of a huge myoma, which is about 15 centimeters in the anterior wall. It's in the fundus. You can see the endometrial cavity here. And so we perform the embolization. And after 1 month, you can see it completely infarcted. Both of the myoma showed complete infarction. But you can see the myoma here is softened, and it's pushing into the cervical canal here. And in 3 months, the shape is changed more. It becomes more soft and pedunculated into the cervical canal. And one day, the patient felt abdominal pain and discomfort, and so she went to the emergency room. And just before she arrived the emergency room, tissue like this exposed. So this is the expulsion of the uterine myoma. But afterward, the myoma is completely gone, and her symptom is completely resolved. This is, I think this is a very important research that volume reduction for large uterine fibroid before the procedure is important. In this study, they compared the large uterine fibroid, which is more than 10 centimeters, if they were pretreated with GnRH, and the volume reduction rate can be up to 56%, and versus the control group, which was not treated by GnRH, 35%. The effect was much better. And more importantly, you can see in the control group, and the vaginal passage or predominant fibroid become endocavitary after the procedure, the percentage is much higher in the control group, which means when the myoma is large, no matter where the location is, you have to be careful about the possibility of myoma expulsion after the procedure, usually 3 months after the procedure. So last, I would like to talk about the question of ovarian function. It is usually asked in the outpatient clinic. Patient cares about the ovarian function. As we said, the anastomosis between uterine artery and ovarian artery is very common. So in general, the rate of premature menopause is around 1%, which is not high. But if we look at the age of the patient, if the woman is under 45 years, the UFE usually do not have impact on the ovarian function. However, if the age is around, is more than 45% or around menopausal, then the chance of premature menopause is much higher. It can achieve up to 10%. So if the patient asks about the question of ovarian failure after the procedure, Usually it is difficult to predict, but age is an important factor to be considered. So I will jump to the conclusion that UFE can provide an effective treatment for uterine myoma. However, selection of proper candidates, especially based on MRI, is important for the successful treatment. Thank you.